for hospitals. I would like to invite Dr. Vijay Agarwal, President of Consortium of Accredited Healthcare Organization, on the dais for keynote address of the session.
Gentlemen, I must first of all thank General V.K. Singh and the organizers to give me this opportunity to share my thoughts on this very important topic of transforming healthcare by leveraging technology. I think whenever we are thinking about this topic, the questions which come to our mind is, what is new? What is the hype about technology? Is the technology that you are talking about, is it now, or is it futuristic? And what is the urgency of, anyway, talking about this technology? And are there any barriers for its implementation? Now, I think a very important milestone that is we have to understand is the arrival of the digital, which is the confluence of many new interlinked technologies. In fact, last year at the Economic Forum at Davos, it was announced that this confluence of digital technology along with the earlier electronic other technologies is heralding the beginning of the fourth industrial revolution. I'm sure we understand that the first industrial revolution was that of steam, the second that of electric, the third one was the information technology, and now fourth is the confluence of many of such technologies. It is also what is disruptive is that they are becoming increasingly affordable. The ever-reducing cost of the various components. And focus is shifting to consumer. And the impact is so much that we cannot call them just merely good. They are transformational. You can see, all right, you see, what do these things have in common? You'll find whether it is they're constantly impacting our lives. So what were the newspapers? We still have in the digital form. Music, you found this iPod. Travel is being taken care, again, digitally. Telephones, we all have. Yellow pages have been all changed by Google. So you will find, and in fact, all these things have been all combined, in fact, now into even a smartphone. And increasingly, there is a rapid adoption of the innovative technologies. This rapid adoption, if you will see, I don't know whether you can see there is a graph which is like that of a hill, where normally the innovations, by the time they reach 1 billion users, was taking a lot of time. So for example, telephones took 110 years to reach the 1 billion mark. Televisions took 50 years. Mobile took 20 years to reach that 1 billion mark. Internet took 15 years. Smartphones took 8 years. And messaging apps like WhatsApp took only 2 years. So it has been an ever-reducing time, which is being now, so there is a very rapid adoption, we can say, of the innovative technologies. Now, disruptions are in all walks of our life. You find this, there is a virtual shopping gallery in a subway in Korea, where people, once they get off to their trains, there is a wall, and they can just kind of click what do they want. By the time they reach home, there is a home delivery. This is by the company called Tesco. There is a US health insurer which is kind of interacting with the consumers by monitoring, by interactive devices, and with the result that with the remote detection and advisory, they have been able to reduce the clinical visits by almost 50%. There is an intelligent, personalized public transport, which is in Finland, I'm told, where not only it's not the cars, even the public transport, buses and all that could be fine-tuned to the needs of the people. Then there are these new platforms making interaction social. So mobile virtual network, now instead of people having their own platforms, for example, for answering the queries of a customer, they are allowing people to answer the queries of the other people and they could be rewarded. So you can imagine that this can disrupt physical retail, it disrupts medical consulting, pathology labs, it can disrupt public transportation, and disrupts call centers and BPO. Google's driverless cars, 3D printing, all these, they are disrupting the automotive industry and disrupting manufacturing. Now, tractor health monitoring, I mean, this was already probably there in the aeroplanes, but now even in things like tractors, the parts inside the tractors are being embedded with some sensors, with the result that whenever it is about to go bad, the information is coming, and therefore much, much easier repairs. And then, of course, Internet of Things with the networking of low-cost sensors, wireless, near-field communication. This is disrupting energy and home automation. And let's understand, they are all here and now. We are not talking about, this is not futuristic. Let me just skip over. These are, of course, 12 technologies which has been kind of picked up by McKinsey, which can help India leapfrog. See, we might have been lagging behind in so many spheres, but these technologies can help. For example, the mobile, we are now much ahead of many, many countries. Now, potential impact on healthcare, we can find that there could be a 60 to 80% reduction in time for a health worker to become fully productive. 400 million with access to quality healthcare with more than 40 decision support systems at a healthcare facility. 50% reduction in the counterfeit drugs valued at 7 billion. 5 to 700,000 people living an additional year with advanced genomics-based diagnosis. Now, these are all, again, real-time examples and not merely something of a prediction. So we all understand that what's impacting the hospitals is the online information searching, the big data analysis, RFID technology, mobile diagnostics, connected devices, wearables and embedded devices, wellness apps, 3D printing and bioprinting, and we can take some examples. Then 5 trends which are driving adoption of technology is, again, the patients, the suppliers, the providers in the healthcare system. The third world countries are looking at new models of low-cost healthcare and technology advances. All these things are pushing us towards adoption of technology. Now, smartphones, along with intelligent sensors, are creating a lot of, I would say, solutions which can help us in impacting healthcare. So, for example, now these are now, in today's date, available, that there are mobile applications. There is a thing called Telescope. So there is a device that is being attached to a smartphone, and that converts this into an horoscope. There are glucose meters, 3D and bioprinting, So what is 3D printing is the process of layering materials, resin, glass, metals, cell tissues into objects defined by a digital mode. Pros of this is it will enable rapid prototyping, opening the door for new research and opportunities in healthcare. Now, already there are people who are using these technologies, like in Children's National Medical Center, 3D printed kidneys, they are kind of making and using it. In fact, one of the research shows that by 2019, 10% of the people in the developed world will have a 3D printed material on or in their body. So this is not something that now we are talking about whether it will happen or not. It is happening. You have mobile diagnostic today. Mobile phones are enabling hospitals to identify and manage health of their patients. The favorable thing, in fact, for this is that it gives hospitals the tools they need to assess their patients and their health at a low cost. But the flip side is that the patients may use the tools in lieu of doctors, risking an inaccurate diagnosis. Now, there are already products which are like iNetra, CellScope, AliveCore, Quantus, Scanadu, IBG Star. These are all available products in the market which are using the mobile technology to make you use it. So, for example, then of course, the telemedicine units, there are mobile telemedicine units. There is this concept of tele-ICU. I'm told that Philips, for example, is already running more than 4,000 beds in this country with a remote ICU program, with a tele-ICU program. The telemedicine can definitely change the entire concept of our reaching out to the rural and the remote areas because of the inadequate availability of the trained manpower. So in healthcare, the last mile primary care system is being addressed today. For example, in Tamil Nadu, in rural Tamil Nadu, this is happening. There are low-cost tablets which have been given for door-to-door household screening of treating about 100,000 patients in a rural area of Tamil Nadu. Geotagging and barcoding identity of all patients are being done. There is a cloud-based health management information system being used. Low-cost diagnostics at central labs with online reports, and smart apps for protocol-based treatment run by the health workers with just about 8 to 12 weeks of training. Online drug prescription, stocking, and scheduling and follow-up. Friends, this is happening. This is happening right today. Same way, a home-based remote health with remote monitoring. The healthcare is, lot of it is going to go away from the hospitals to the homes of the patients. So result would be that as of today, you find that in the hospitals, you have about 10 to 20, 25% beds which are the ICU care beds, and rest are all general care beds. In the coming time, this is all going to reverse. You are going to have about 80 to 85% ICU care beds because all the general care beds would hardly be needed because of the presence of a very strong home healthcare program. So these are very low-cost medical diagnostic tools using smartphones. We gave you this example of Netra. This is a cheap prototype eye testing device was developed by MIT. All it does is it puts a smartphone, and on top of it, they have given a contraption, and which is giving an auto refraction. Healthcare, by using the big data analytics, is being used for, let's say, locating the density of the dengue cases and the things which are causing it, so we are trying to about tackling it. The big data analytics, as I'm sure that you can all understand, we use today in our day-to-day work, just what you see in Google Map. So whenever you are coming, you put on the Google Map, you come to know that you see a green line, yellow lines, and red lines to see whether there is a traffic congestion at some particular place. Now that data is not coming from satellite, friends. That data is being picked up by the consumers, by the users who are there traveling on the road. That data is being picked up to see and analyze, and same way, we are going to have, once this data is being fed into this thing, that if I can know that where are these dengue cases being picked up, we will be able to take immediate remedial actions. There is a technology help which is going to be used for picking up fake drugs, and that has already eliminating the counterfeit drugs could save about 700,000 lives in a year, and a lot of money. So the customers can verify the authenticity of the drug by sending a 12-digit message via SMS to an authentication center. The unique codes are printed with approval from the pharma companies, and Hewlett-Packard is already in talks with Cipla, Tablet India, and Kama. And this is already being implemented in Africa, with most Indian companies having adopted it in global supply chains. Now let's talk about a few minutes about the barriers to technology adoption in healthcare. Commonly mentioned reasons are there are concerns of regulations, approvals, safety. These are mentioned as reasons as to why we cannot go ahead. Concerns of privacy and data protection. Lack of common standards on EMR and diagnostic medical devices. Some technologies, they will say they don't address the real problem. And of course, there is a lot of resistance from physicians to say that it slows down our functioning and thinking, and the technology is impersonal. Main barriers, though, are that there is no burning problem, there is a lack of urgency. We're not understanding. It says, what is the hurry about it? Culture is not amenable to change. There is a lack of vision and leadership drive, risk aversion, and a belief that it is expensive and unaffordable. All these things are slowly and gradually, they are melting away. People wait for it to kind of show its usefulness, but as I showed, that the adoption of technology is now much earlier than whatever it used to be. These are common across sectors, and disruption is happening everywhere. So new digital technology are here and now and evolving fast. And I would say that, again, at this economic forum where they talked about the fourth industrial revolution, they also talked about that this is going to impact the healthcare maximum, and it is the healthcare professionals who are least prepared to make use of this fourth industrial revolution. So digital technology, they are affordable, and cost of adoption is relatively low. Conventional healthcare is not going to solve all the problems of our country, whether primary, secondary, tertiary. We need to leverage the digital technology. It needs a change of our mindset. If we resist, we risk getting marginalized. India has unique opportunity, as we have not the baggage, and we can leapfrog as we did with mobile or with Aadhaar, etc. So we work with health tech companies to create India-specific solutions. This is the opportunity for healthcare. to transform. Let's collaborate to make it happen. Thank you very much, ladies and gentlemen. And I must thank Mr. Som Mittal, who is the earlier NASCOM president, who helped me preparing this talk also. So thank you very much, sir.
Thank you, sir. Request you to please occupy the distinguished chair on the dais. I now request session moderator, Dr. Arti Verma, Senior Vice President for Medical Quality at Max Healthcare on the dais. Also, I request all the speakers of the session to please come on the stage. We have with us Professor A.K. Gupta, Medical Superintendent-cum-Professor and Head, Department of Hospital Administration. Mr. Partha, Healthcare Leader and SME, IBM India and SA. Mr. Surjeet Thakur, Director, IT Strategy at TrioTree Technology Private Limited. Professor Arti Maria, Professor and Head, Department of Neonatology, Dr. RML Hospital and PGIMER. Now I request the session moderator to please commence the session.
Thank you, Avantika. So we welcome all the speakers onto the stage, and our first speaker is going to be Professor A.K. Gupta. We are honored to have you here, sir. Professor Gupta is the Medical Superintendent and Head of Department of Hospital Administration of PGI Chandigarh, and his career in hospital management started in All India Institute of Medical Sciences, New Delhi. He has a vast amount of experience, and at the operating level as well as leadership level. So, Professor Gupta, please, can you start with your talk?
You have to help me quickly. Good morning and greetings from PGI and Chandigarh. My dear friends, I will ask you one odd question and then I will start. Have you faced challenges in your life? If yes, raise your hands. Virtually everybody has faced challenges. My dear friends, I also faced challenges. One fine morning, I was appointed as a medical superintendent at PGIMER Chandigarh. That's the second largest institute of the country after AIMS. I was working at AIMS. Lo and behold, never knowing what will be the challenges, I was inundated with the many, many challenges. Faced it, got bruised, injured, but at the end of the day, they was very satisfying. And this presentation belongs to that. Since some of my colleagues have helped me, I have included their names. Forget about me, time is a sense, time is short, so I will be a little fast. A little bit about my PGI, where these innovations took place based on the challenge we face. This is an overview of the PGI, the bird's eye view. We have got roughly 2,000 beds, second only to, as far as infrastructure and bed is concerned, we are second to AIMS New Delhi. This is a number of attendants. Somebody, my namesake, the legendary Dr. Anil Kumar Gupta mentioned that the PGI have 10,000 patients a day. Absolutely correct. Last year, we saw more than 2.5 million patients, that is 25 lakhs. And this year, it is projected to be much more. Admissions, I will have particularly last year, it was 89,000 patients were admitted in my institute. There is a significance, kindly remember it, I will share it. Now let's go to the core presentation. Somebody very correctly said, smooth seas do not make good sailors. Absolutely true. Steve Jobs is my motivator. He says, innovation distinguishes between a leader and a follower. And that is a motto we follow at PGI Chandigarh. Creativity is thinking up new things. Absolutely correct. But innovation is doing those things. And here is the first, our first experience, court summons. We invented tele-evidence, nothing new. Somebody, I think it was again Mr. Anil Kumar Gupta, who said, you have to find newer ways, newer application, newer tools. We did not invent any new thing, but we invented newer application. That is recording medical evidence through video conferencing, which we named it as tele-evidence. But there were plenty of things which we have to tie up. And what were those? At PGI, we were getting around 2,000 summons each year. And huge resources were lost, particularly human resources. Our budget is very tight. Lots of financial resources was also there. And there was long waiting list of patients for the surgery, for admission. And when the doctors appear in the courts, they lose the consultation by their doctors. But you will agree with the doctors apart from other jobs, they have to provide medical evidence to the courts. And what we did, we innovated out of the existing technology. That is, we started video conferencing. But it was not a simple journey. We took the help of a couple of things. First, there was a change in Evidence Act. Section 65 says that if an evidence is recorded through the video conferencing, it will be taken on the record. Then there was some innovation in information technology, where it was said that any expert opinion given through video conference is taken on record. There was a e-health was there, but then similarly courts have also got e-courts. And above all, the most important thing was willingness on the part of the judiciary to come on the board. And lo and behold, I joined hands with the High Court. We made a couple of administrative orders. These are the couple of orders which the Honorable Court has issued for the video conferencing. This is a communication. Of course, communication is done by my colleague since I was away on a WHO assignment that time. These are the orders. These are standing operating procedures. And lo and behold, coming to the core things. What were the challenges? I'm very short because they're setting up of the new networks. Integration of the networks with the network of the honorable courts. Quality of the networks was a very big issue. Scheduling of tele-evidence, even now it's a big challenge. Casualness on the part of all the stakeholders, particularly junior, subordinate judiciary, the doctors, and others, was a very common thing. And above all, punctuality was a huge casualty. We addressed all these issues. And what was the results? When we started, we were able to do only 554 per schedule, but only 333 were conducted, 56. We went on increasing. Till today, till 31st of August, we have done around 3,000 video conferencing. That means 3,000 man days have been saved. And what was the saving? Each court evidence from the PGI led to an increase of expenditure of 10,400. I have got calculation. So far, we have saved more than 3 crore rupees. Similarly, reduction of carbon footprint is to the tune of 148 tons. That is worked out by the concerned experts. This is our. So what was the saving? Huge saving on fuel. Before tele-evidences, the fuel consumption was very high. In 2014, there was a reduction of 54%. Later on, it was 62%. And last year, it was a reduction, saving of fuel by 70%. Similarly, mileage covered by the vehicle got reduced till today by 67%. And above all, the man-hour saves were 72%. And lo and behold, it was published. This is a video shot of the tele-evidence. The court is sitting there. Court is there. My doctors are there. Judge is sitting. The advocates are there. And lo and behold, the Honorable Union Health Minister inaugurates the same. This is myself, my director. It was inaugurated on 30th of December. This is a video film which I will skip because it will say, because the Union Health Minister on the House in the Parliament on 3rd of May 2016 announced that this is adopted as a part of Digital India, and all the courts in the country now will be linked through video conferencing. So that is the video, will save the time. And this has led to an award. I was away to USA, hence my colleagues, whose names you must have seen, they received the award. So next challenge, kindly correct me, there will be hundreds of innovation. I will stop when you ask me to stop. Average length of stay. Those who have worked in the hospital, they know higher the average length of stay, less will be the number of patients treated. So, and more will be the hospital-acquired infection. Reducing average length of stay makes a tremendous sense for any brass tack administrators. And this is what we did, and we used a management innovation decision support system. And it is simple, we didn't do anything. I believe what we did, everybody knows, I have already mentioned, I'll skip. What we did, we innovative use of the existing technology. Hospital information system, SMS and emails are used. Now, I will ask you another question. How many of you have ever booked an air ticket through on internet? Kindly raise the hands. Almost everybody. Sir, the same technology which airlines people use or the banks use, we use the same. What we did was a program was developed that is called embedded technology, got it embedded in hospital information system, found that the hospital stay on an average at PGI is around 8 days. We decided that we should inform our doctors at the end of the 7 days through an SMS and email. And we embedded that in our hospital information system. So what happens is, on the 8th day at 8 a.m., of course, because we never wanted people to wake up at 2 a.m. when 7th day has ended. So on 8th day at 8 a.m., any doctor who has got the patients admitted in the wards, having stayed beyond 7 days, will get an SMS and email. One of them is, this is an email, which says, this is a computer generated. Sir, you have got a patient, such and such in your ward, and whose stay is beyond the average length of stay at the PGI. Our aim was not to tell him to discharge him, because that is totally falls within the domain of them. I'm an administrator, of course a medical administrator, a doctor. Our aim was not to tell, it was just a tinkle. Similarly, he will get a email also, and my dear friend, let's see the results. Before we started, it was 7.9 days. Over the year when it got improved, the average length of stay came to 7.7 first year, then 7.2, now 7.1. My dear friends, it is statistically significant. We got it published, and the number of patients by simple innovation has increased. In number of beds have remained same, stagnant at PGI. It was 2014, 81,000 patients were admitted. This year we are anticipating 93,896 persons will be admitted as per the status. Simple innovation, same number of beds, more than 12,000 patients have been admitted. And if those who are health economists, they will know each patient admitted in the government costs a huge amount, and PGI is no exception. And saving maybe more than 100 crore rupees a year. It was awarded most effective healthcare technology by none other than by the healthcare group, those who know him, Dr. Srinath Reddy, whose name was also mentioned by Anil Kumar Gupta, and it is me. I think it's me.
Excuse me, Professor.
Time is over. I will complete
3
quickly.
minutes.
I will not say. So similarly, donations, use of motivation, feedback, and technology. We quickly, and lo and behold, there were 264 corneas. Now this year 778. This has won us not only award, I got invitation from the Los Angeles, presented it, and now this innovation has won an award by World Health Congress, and I will be there in Taiwan to receive it on 7th of November coming. Similarly, there are many of them promoting cadaver donation. Let me share the motivation team approach and stop. I will end after this. By innovation, what we have done is, in 3 years, In 3 years, the cadaver donations were 15. In the next 3 years, it was 24. But till this year, only 8 months, cadaver donations have led to 62 kidneys, 13 livers, 6 hearts, pancreas and lungs, which we have implanted and also shared, and also created green corridors, 6 green corridors in a single day, which may be the Guinness Book of Record. We are looking into it. My dear friends, there are many innovations. I'll skip about it. Curbing smoking, my colleagues tell me this is the first time in the world that such an approach has been happened, and not a single person ever smokes in my institute. And hundreds and cases of cigarette and BDs have been caught, incinerated, and fine imposed on delinquent officials. And there are many more prisoners. We don't admit it. Now, clinician, before admitting a patient, tell them, hey, ask the doctor, MS, can we admit it? No, nothing. No prisoner, particularly the politicians, when they fall into the trap of police cases, they land not in the jail, but in the hospital. But that doesn't happen, Vijay. My dear friends, I will skip and conclude. This is a checklist. We do it. We read about 360-degree appraisal, but have anybody done in the hospital? No, we do it, and we have made a tremendous improvement. Time constraints that I will not be, but those who are interested in asking me during lunch and tea, we can always share these things. Fake medical certificate, nobody ever submits fake certificates because he will be facing the music, Lord and order. This is the, this are 10 numbers available in the institute, throughout the institute. Anybody, even you and me, even if we are in New York or in the Mount Everest, we can contact any of the 10 round the clock and get our issues resolved. Immense benefit. We can have a comfortable sleep at home, all senior persons. To conclude, my dear friends, I will say the human resource is the greatest asset. But scratch a problem and you will find a human element at the bottom of it. Aim is to motivate and improving the knowledge, skills, and attitudes of the employees, which will benefit the system as a whole. If you want to be successful, it's just this simple. Know what you are doing, love what you are doing, and believe in what you are doing. My dear friend, future of management is that there will be more problems than human capacity to handle that. Motivation and use of technology is the way forward. Thank you very much, sir.
Thank you so much, Professor Gupta. This was a really inspiring talk, and I think PGI is one of the best institutions of the country. We are all very proud and privileged to have you here on the dais sharing all the wonderful things you are doing. I wish we could have given you more time to share all the good work that you have done. However, what I think as a flavor has come out is that whatever you have done has been very homegrown. You have innovated internally, used very cost-effective and simple technologies to improve efficiencies, reduce waste within your organization. My congratulations to you. We can take 1 or 2 questions in the interest of time, so we'd like to open the session to questions for Professor Gupta's talk, if there are any. Yes, Dr. Lal.
I'm Dr. Arvind Lal.
Sir, everybody knows you, sir.
Thank you very much. The question is about costing. The government of India, especially the health, our own Department of Family Welfare and Planning, they are trying to control costs. You have read in the papers that the stent cost has been frozen. The cost of knee implant is going to be frozen. So we in the private sector are trying to, get to the bottom of this as how can we have kind of a universal system in which the costs are, made transparent of a particular procedure in a particular hospital. I'm sorry to state that the private, participation here has been there. Max has come forward, Apollo has come forward, CARE has come forward, but not the government hospitals. So I would like to make a request to you, sir, that we have to work together because otherwise the costing is going to get out of hand. So I hope, we can look forward to some cooperation from your side.
It's working. Yeah.
It's not working.
Yeah, boliye.
Sir, you have asked very pertinent question and very challenging one. In the last 21 years, I have been at the helms of the affair at the PG. I have tried my level best. It's absolutely impossible to get the clinician to fall on the track. And this is very difficult in the government hospital. With due apology to any clinician over here, they are very difficult to handle. And they don't fall on the track. I had tried my level best. In last, not 21 years, but in the last 19 years, I have been asking my cardiologists, kindly give me a package deal. And they have not been able to finance. I will not pass any remarks which are adverse to them, but for reasons everybody knows, why should I say it? It's absolutely fine. And sadly, which I say, the clinician, the top institute, since I have worked at 11 years at AIIMS New Delhi also, and no offense needed, but most of the top people, they suffer from pillar syndrome. The moment he moves it, the building will come down, and they are very difficult to handle. It's absolutely essential. Government hospitals are huge jugglers of money. People say it's cheap. Absolutely no. They are very expensive, and the cost nation a huge amount of it. But the taxpayer pay it, the common man doesn't know it. And government has to find a way out. And because there are a lot of groupism, it's very at least I have failed in my institution. And my speeches I have to tried. Professor K.K. Talwar made immense efforts.
But I think that's a very valid question, and it's a challenge facing the industry. With your, influence in the government sector, I think a way forward would be for you to try and encourage government participation at a policy level, somewhere from the ministry level, to, partner with the entire industry to take this forward.
One last word. Once I was deciding that you are buying Gamma knife worth 25 crore rupees. And I said, what will be IRR, internal rate of return? He said, what is nonsense you are doing? This is not valid for us. Shut up. You administrators are known to come out with juggleries. No, this is not valid. I said, you are kindly do we do research, we do teaching, and we do patient care. I said, you earmark 25% to the research, you earmark for 25% of the to the academics, 50% to the patient care workout. No, absolutely not. And I have failed because they are a huge, powerful group. But the question is absolutely valid. I wish I could find a way, and if I succeed, I will certainly share with Brigadier Lal.
We will approach you, sir, officially from NATL private industry side and share with you the format. After all, there has to be a correct way of approaching this problem. So if you allow us, we will come to you. We've already approached All India Institute. We are getting somewhere, but maybe, we can be helpful.
Sir, I appreciate your efforts, but I am not the final word in the PGI. Though I will personally, on a personal level, I support it, but we need to, if there is another person superior to me, I have to take his
We'll come through
Thank
proper
you.
channels.
But it is welcome, sir.
I think it'll start, you start a good dialogue, and you can take this forward during lunch hour. Yes, Vijay?
No, I thought that the issue raised by Brigadier Lal is of paramount importance in the sense that today the private sector is being labeled as charging excessive and unreasonable, and they are fleecing. The issue is this, that you can call any cost unreasonable only when you know what is the reasonable cost. And the unfortunate part is that nobody in this country is trying to understand that what is a reasonable cost. And to understand a reasonable cost, I think the costing, at least in the government sector, which is not running on any commercial motive, is the beginning, is an extremely important step. Of course, taking into consideration that the infrastructure cost, which the government may not be able, you have to take certain assumptions to put value to that land and building and everything. So I think we need to kind of work on it very, very urgently. And
so I think Vijay also represents a very important stakeholder organization, which is the Consortium of Accredited Healthcare Organizations. And I request Vijay to please collaborate with Dr. Lal through NatHealth and take the agenda forward for this very, very crucial subject.
And
Yes,
I must put on record, you know, the human services rendered by Max Group. Thank you very much, Max.
That's nice to hear.
I'm Dr. Gaur from Onquest. I think I'll just probably say what Dr. Vijay has been, I think, one of the discussion we had with him. Only if what we can do is probably when the patient gets discharged from the hospital, or government hospital, if he is given a discharge slip which says that your treatment admission costs 1,000 rupees, discounted 1,000 rupees, that's it. Probably that will start an impact outside. Because some judgment, because if we do charge 1,000 rupees for MRI, we are overcharging. Hospital is charging 1,000 rupees, then probably that is something start probably made from somewhere at that end probably.
That's a good suggestion. So in the interest of time, I'm afraid we'll have to take these questions for Professor Gupta, subsequently during lunch break. So if you'll pardon us with this. I would now like to invite our esteemed next speaker, Mr. Partha De, who goes back a long way, more than 17 years of working together in the past. Partha is a passionate healthcare professional with nearly 2 decades of experience in both the provider-payer segment, healthcare IT, and process consulting in all his areas of interest. He's well versed with a lot of computer technology, such as HL7, HIPAA, DICOM, and other health IT-related protocols. He is currently leading the IBM Consulting, Sales and Delivery in India and South Africa region, serving healthcare customers across the region. So we welcome Partha to share his expertise on how technology is impacting healthcare.
Thank you, Dr. Arti. Good morning. Thank you very much for having me here. It's an excellent opportunity for me to be present in this August gathering. And as Dr. Arti said, it is a nostalgic moment. After quite a long time, three of us were sitting together, and all of us used to be sitting together in around 2000 when we have started working for Max Healthcare. So I don't know how Dr. Singh picked up this panel. When I was seeing three of us sitting there, I was thinking whether it's a coincidence or they wanted us to be together and spend some time. So thank you, Dr. Singh, for this opportunity. Coming back to the topic for the day, I think Dr. Agarwal has done most of the work for me. So Dr. Agarwal, thank you very much for showing that excellent presentation. You have covered most of the IT enablement that is required nowadays, and you have already discussed the trends. So what I would like to do, with Dr. Arti, with your permissions, I would probably change the format a little bit and would like to go ahead with the question-answer format more so that we can have more discussions. I have a couple of thoughts to share. What we would like to do is probably speak for 5-7 minutes and then open the forum and so that we can all learn from each other. Dr. Arti, if you permit, then we can go ahead with that.
That's great.
So this is the InnoHEALTH forum. So innovation is a core to us. So we have to think about innovating all the times that we are doing. I thought of introducing IBM. A lot of people must be thinking what IBMers are doing over here. This is more a healthcare of conferences. So if you look at, as an organization, how we want us to be known into the marketplace as a cognitive solutions and a cloud platform company. So let me explain a little bit about this, because you may have known IBM differently. A lot of cases when I keep meeting my colleagues from healthcare industry, a lot of guys say that how you are working in IBM. You are a healthcare operations guy, you are supposed to be working in hospitals, and what do you do in IBM? So in IBM, we have a good amount of healthcare professionals. We all are working inside the organization, but we do work for the hospitals and health insurance organizations into the marketplace. From a IBM core business perspective, now there is a change, and the focus is primarily being a cognitive solutions company. What is the meaning of this cognitive solutions company? I would like to spend 1 or 2 minutes about explaining these cognitive solutions because this is comparatively newer animal into this technology marketplace. And also, we are looking at using this power of innovations, data, and expertise to improve the business and the society. Now, this is a very important statement. So how we would like to impact is, we would like to pick up the data, we would like to use this analyzed power of the data to change the business and the society. And we'll try to see how we have already done some of the work in this space. Let's look at some of the high impact technologies which hopefully would impact the healthcare organizations in coming, let's say, 3 to 5 years. A couple of them has already started impacting. A couple of them would be impacting more than what they are doing today. Starts with IBM Watson. Watson is cognitive. Means Watson has got certain ability to think, which is little different than a programmatic systems. Watson can read. Watson can read as a natural language. Watson can read English and a couple of other languages. Watson, hopefully, very soon would be reading a lot of Indian languages, including Hindi. That's not very far. And when Watson reads these languages, it reads like a human being, and it can make summary of these readings. And Watson has also been trained to read medical languages because the medical dictionary is completely different than a regular English that we use. Watson has been trained to read a lot of specialty medical English like oncology. In oncology, we used a lot of synonyms which is different, and it's difficult for a regular English-speaking persons to understand, but Watson has been trained to understand those. So Watson, being a cognitive computing system, is going to impact a lot, all of us, when we are practicing healthcare. Multiple areas Watson is going to impact. One of the area, what we have seen is a huge amount of impact Watson is already having, and in India we have Manipal hospitals as our anchor client. This is in the area of decision support. What we are trying to say, Watson would be helping the physicians to take decisions by having all the information he or she wanted to know at the point of care. Now, at the point of care is very important over here because a lot of times the informations are available, but it is not available when we are taking a decision next to the patients, be it in the emergency, be it in ICU, be it in OPD consultations areas. So Watson would make all the information with a recommendation as a decision support available to the physician while they are treating the patients. Now, at the day end, it's a decision of the physician. They would definitely take the decision, but all the information would be provided along with the rationale and the evidences why a doctor would take that decision. And this is a completely based on evidences, and the evidence would be made available to the doctor, and if the doctor wants, he can also share that evidence with the patients. So this is one of the very important area where Watson plays very important role. But Watson, being cognitive, does not limit his activity only in healthcare. It works in multiple areas and spheres in life. Watson is helping us to find out a good recipe when we are cooking. And you can check this. There's a lot of YouTube videos on Watson's and how you can find out a very good recipe while you would like to cook something new. Watson is helping a lot of financial sectors where it is working as a advisor and advising people that where to invest and what not to invest. So, and these investment decisions are completely evidence-based. But at the day end, it's your decision. It's a decision support tool. It is providing you all the information, but at the day end, the decision has to be taken either by the physician or the person using it. Here we talk about, I understand artificial intelligence is one of the very important topic, and all of us are very keen to understand. So here we would like to talk about, rather than using the word artificial intelligence, we talk about augmented intelligence. So it is going to provide additional information to augment the knowledge base of the physicians to take the decisions. And I will leave this topic for my friend Surjeet. He would speak more on the artificial intelligence, and we're keen to know more from him. Moving forward, IoT, or Internet of Things. This is something that has already started impacting our life, and it is going to impact more in next coming years. We are all now connected, and the connected ecosystem is going to change the way we behave. And this is going to be applicable to all the provider and the peer organizations in healthcare. I'll come to a couple of examples later on. Blockchain. This is the latest, and we keep bringing some latest to show that, we are ahead in the curve. Anybody has got any blockchain use case in mind in healthcare? Ashish, this is not for you. So blockchain is a new thing so let me spend 30 seconds on blockchain. So what is this? This is a common ledger system where any changes needs to be done, requires permission from all the people participated in this transaction process. So probably my way of defining how blockchain is and how this blockchain as a technology can be leveraged for us in healthcare. So if there is a data, and this data requires changes, all the stakeholders would get informed, and depending on the situation, the stakeholder permission is required for the changing of the data. And this is an excellent case when we talk about where we don't have trust. Payer-provider interaction. Insurance company does not believe the hospital, neither hospital believes the insurance company, because both of them keep thinking that other guy is doing something wrong somewhere. Now, this is an excellent example where blockchain can really play fantastic role. Other examples are, you are also showing this counterfeit of drugs. And here we have our friend Ashish. He can show you something in his stalls in Medicia, where they have developed something where this counterfeit of drug using blockchains can be completely eradicated. And here, if there is any change is required, starting from the manufacturing to the person who is using the drug, there are 6, 7 stakeholders would be required. All of them need to be notified, and their permissions is required for any changes in this process. So blockchain is an excellent tool, technology tool in our hand, whenever we see there are multiple stakeholders involved in the transactions, and we want to build a completely trusted environment in that transactions ecosystem. So this is, and there are several use cases that we are working, and this is reality, and it's not that this is going to come, this has already come. Now we need to see how we figure out the better use cases for blockchain over here. So last one is talking about the cloud. Now cloud has come down from the sky to us. Earlier we used to all think about what is the cloud. So we have to put the data and this in the cloud and kho jayega. We don't know whether the data will be if we're putting on the cloud. But all of us have started experiencing cloud in our life. All the application in social media that we use, this is all in cloud in a conceptual manner. So a lot of cases when I meet hospital clients, they keep talking about that if I put something on cloud, it will never come back. It will get vanished. And then what would happen? But most of the time, what are the different social media that we are using today, unknowingly that all of them, completely all of them are only on cloud. And we don't question that whether my Facebook will work or my WhatsApp will work or my LinkedIn will work. And we keep thinking that our own data may have a problem if it is going to the cloud. Cloud is more secure than your own data center. And cloud is a reality in life. But definitely, we have to find out the right mechanisms for moving to the cloud. And all of the technology that I'm talking about, be it cognitive computing or Internet of Things or blockchain, all of them are going to be working on cloud. We have to embrace cloud. There is no second thoughts about this. But definitely, the cloud is a journey, and we have to decide that how we'll move from our on-prem to cloud. This is a little technicals, but the point, these 4 points I wanted to leave it with all of you, telling that these are the 4 different things, what we think is going to change the way the healthcare is being practiced today. Questions? Yes, sir.
Hi, this is Molish. I am from Deloitte. I had a question regarding the technologies that you talked about. I work for the healthcare sector in technology, so I would completely second about all these technologies being high impact technologies. But what about the core, which is the data? Digitization of data in healthcare for a country like India. We don't even have EMR, that's the basic thing. We don't have it in most of the hospitals today. How do you think, how long will it take for these technologies to come to a country like India?
Okay. So here this is something like, I look at this like not having something is, sometimes a bonus for us. This is something like what has happened to the telecom industry. We didn't have landline, we have smartphones. So personally, I'm very confident that we are going to see the similar sea change of adoptions of technology, and we'll be directly adopting some of the technology for future much faster than the Western countries. And this is becoming a reality. If you look at when, in around 2000, I was talking about Max Healthcare days when we have started, that is the time when we used to tell the doctors how to operate the computer, when we started talking about having EMR. Nowadays, everybody knows. You can't have situations where they are not using computer in their life, knowingly, unknowingly, because their smartphone is also a computer. So today, if you look at the adoption we need to drive, there's a consumer push is going to make it happen. Now, my complete belief that this total EMR adoptions will be driven by consumer push. Earlier, what we have done is, as a technology company or working for hospitals, this was more like a management stakeholder decision because they wanted to get some analytics report out of it. So the EMR implementation cannot be driven by what a hospital administrator would like to see in his report. That was most of the cases, the requirement for implementing EMR without looking at the efficiency that brings to the operational process. Now, the consumers, the people who are availing healthcare services, they are going to drive it. In some point of time, you will find out people would reject those hospitals who are not using EMR, and through their mobile apps, they are not able to get access to their reports. And I think this will be the biggest push for EMR. Next 5 years' time, I don't see there is any hospital would not have any EMR.
So apart from consumers, as you said, who would do that push, don't you think we should also have something like coming from the government side, internalizing it in a way of a policy, just like US did with HIPAA and high-tech. We could do as a country, just like we did with Aadhaar, we could do similarly. The government can do that, standardize the EMRs, standardize the digitalization of data in healthcare.
This is already there. The EMR standards are there and hovering around there for quite some time. We all were part of EMR committee. God knows how many meetings we have done and what are the suggestions we have given. I am not too sure whether all of us are aware the EMR standards are available for us to adopt. Now, we can keep waiting.